Um, I'm a faculty in RP Center, and we had an aim that diabetic retinopathy screening should reach to the community level. And a project was started as Innovation Fund project with Sight Savers in 2013, where we started screening of diabetic retinopathy at community level with the help of optometrist and using a handheld fundus camera. It's a non-mediatic fundus camera. And under that project, it was an ambitious project. And what we found that the people who identify with diabetic retinopathy in the slum areas, they were not responding, they're not coming to the hospitals. So in this study, I tried to assess the reasons for the retination not responding, not coming to the hospital. As we know, diabetic is a public health problem. It is taken as an epidemic, and diabetic retinopathy burden is quite high. So we definitely need to take it to community level. And especially when we talk about slums, the awareness level in slums is low. The people from slums, they don't like to come to the hospital, the reason because of daily wages or something. And probably they even are not aware about whether diabetes can affect eye or something. So it was very important that such kind of program should be started in slum areas. As I mentioned that there are various techniques, either indirect ophthalmoscope, direct ophthalmoscope, but something like non-mediatic fundus camera, and weight of this fundus camera was just 480 grams. That is very much portable. You can take this camera anywhere in the community for the screening camps. And of course, we expect that most of the patients who are seen and identified as diabetic retinopathy in the community, they should come to the base hospital. And our aim was to assess what are the reasons. The process was very clear. We are conducting camps. For every 5,000 population, we are conducting camps. It was active approach also, through publicity also, and we also used to meet the local pharmacists and doctors to refer patient to us. Patient identified, they are screened as diabetic retinopathy, and they are referred to RP center. A total 277 camps were conducted in 1.5 years, almost one camp per day. And 9,435 non-diabetic patients, they attended this camp. In fact, we could approach to nearly 15,181 diabetic patients, and out of them, these 9,435 patients, they reach. A detailed assessment was also done for the risk factor, their clinical evaluations, BP, sugar, everything in those camps, and ocular examination. Out of these 9,000 patients, 8,432 patients, we could grade them for diabetic retinopathy using fundus camera. And out of them, 1,136, nearly 13.5% patient, they were referred for diabetic retinopathy. And out of them, only 420 patients, they reached to RP center. That was something very, very bad. That's nearly 1/3, or 40% patients are reaching to us at RP center. And 63.1% patients, they were not reaching to RP center. That was the result of the study. Even the free services are available. We have best of the retina services. Even sometime if patient were saying we provided transport also to the patient, still we got this much number of patient. Our chief, they gave free injections also to the patient. Investigations were totally free. That was the status for this thing. When we assess, what we identified that the females, they were resistant, they were less, the attrition was higher among females. We can understand that in community they easily come, but when they have to come to big hospital, probably they shy in that thing. People above the age of 60 years, their response was less, attrition was more. Probably they need some people for the accompany them. That may be reason it was not there. The family history of diabetes, though slightly higher number was there, but it was not significant. Duration of diabetes, we're suspecting those with higher duration, they may come, but that was also not significantly associated. Then DR stages, we thought that people with higher severe diabetic retinopathy, they may come, but even that was not also significantly associated. Then one of the factors which our people were reported, that their awareness is low, their vision is better, they don't come to hospital because they feel that when the vision will be poor, only then they'll come to hospital. But we assess for that also, surprisingly, that was also not associated. Even people less than 6/60, the odd ratio was 1.2. and it was not significantly associated. Patient with complications, that was also not significantly associated. So that was the status. Those factors, most of them were negative. So attrition was 63.1%. The factors which could identify for attrition was mainly two factors. It is the old age and the female patient, and rest of the factors were not there. But all this study which we did is the post study, and it was basically a quantitative study. That means after the result we are assessing the reason why patient is not coming. Probably a better way of study is doing a qualitative study where in detail patient can be asked the reason why they are not coming. In fact, we have started this phase of the study also. Now patients are being qualitatively assessed the reasons why they are not coming. Thank you very much.
A good study. I tell you one thing about my own experience. About 20 years back, I was having a resident there in the department. Her father was working in an industry. He was a director there. I asked that I want to do this survey on diabetic patients. So the workers refused, that they don't want to get this done, otherwise they will be medically proved that they are not fit and they will not be. So this is a big problem in our part of the world, where even if you go and do the services, many a times they say that what is the interest of the doctor that they are coming. So these are some of the problems, and the causes should be known why they are not coming. That has to be mentioned, and it can be a very good study if we come with the causes why they are not coming.
Yes, it is a indeed a very good study. But the thing is that everyone knows nowadays, because the diabetes is going up to just like a cataract. And if we take this treatment pattern to their home only, then only we can save the people. So this is very important. Now you can just make some studies like that. If you can take the instruments to them and do the treatment there at their home only. So otherwise the people will not come definitely, and you are going to get a huge number of diabetic blind rather.
Sir, I would like to respond to this thing actually. Yeah, some projects are going on Nayantara where laser is being conducted near to households. But what we are doing is now we have started Vision Center. RP Center have 25 Vision Centers, and this Vision Center approach is better than the camp approach. When camp, only one time camp is organized, even the follow-up we are not aware. But in Vision Centers, there are fixed facility centers, their patients are reporting and their compliance is better, sir.
I think in this study, I'm not blaming, but when the people are screened, the person who is normal, who has got certain damage and who is at the worst scenario, probably all are tackled in the same way, in same manner by the person who is screening. And at the time, they may not be knowing the severity of their disease. So probably it's the proper time to handle those patients at that spot only, with all equipments and with all things available with you. I think that's the only solution.
So
in this specific study, we had counselor also. The optometrist was screening and counselor was referring. Even after this is the status. Maybe it's a big hospital and people have fear to coming to such big hospitals.
That's true.
Okay, thank you. So next I call upon Dr. Ruchi.